some ultrasound was done in which do not use these knuckle thickness and bit and Doppler maybe what else. So all these things has to be very, very so try to give history in the history mein about the clinical features which you have asked, which in first trimester, first you have told, or second and third trimester, what other features you have to ask that you should be stressing on.
Any excessive weight gain, that any infection, fever that she might have had, any foul smelling discharge that might have been present, any leaking pee per vaginum that might be present.
So this is a clinical case and we have to be focusing on the clinical aspect and his ticket. Okay.
Yes. Then the labor pain started 12 hours prior to delivery and the patient was admitted in labor room. The baby was born via cesarean section. Post-delivery, the baby had a weak cry. Initial care was given. Some oxygen support was also given to the baby according to the mother, and the baby was shifted to the ICU after that. The birth weight of the baby was 1.8 kilos. He received medication within 12 hours of life for his lungs, according to the mother, and he was placed on a mechanical ventilator for 4 days, after which he was on oxygen support till he was discharged on 14th day of life. During the stay, according to the mother, there was no history of any abnormal body movements, seizures, feeding difficulty, abdominal distension, yellowish discoloration which required any light or transfusion. After this, the parents noticed that the child was having increased excessive increase in head size, which was gradually increasing till 6 weeks of life. This was not associated with any history of excessive crying, irritability, abnormal body movement, eye movements, decreased responsiveness, fever, rash, difficulty in passage of stools, urine, or a swelling in back. And it was associated with difficulty in head holding, which was till 3 months of age. Ma'am, should I go ahead?
Yeah.
For the above mentioned complaints, the parents showed to a specialist. Neuroimaging was advised and supportive care was told to them. No surgical intervention was planned at the time. The infant was started on certain exercises, after which child has showed improvement over the past 2 months.
Right. So the initial consultation was at 4 months of age.
Yes, ma'am.
After which the intervention was started, and then they reported that there is some improvement after neuroimaging was done, and no surgical intervention was done, right? Anything you want to comment about the behavioral pattern of the child? How has it been? How is sleep? How is the feeding pattern? How is the irritability? Do you think that is important in the initial few months?
Yes, ma'am, it's important. Because according to the parents, initially the child, the feeding of the child was always been on formula feeds. He has never been able to breastfeed, and according to the parents, his response to them was initially a little slower. They felt that he was just not responding so well, but after certain exercises, they feel that he's now more responsive towards their movements or any toys that they're playing around the child with, which I'll comment upon in the developmental history also.
All right. So initially he wasn't as interactive right? So there was some behavior issue, right? Okay.
So based upon the developmental history, the baby achieved head holding at 5 months of age, which was 3 months of corrected gestational age. So basically 1 month ago, only the child has achieved head holding. He started looking up in prone position at 5.5 months. Currently, he can sit with support, but cannot roll over at 6 months. His fists were completely open by 3 months of age, and he had a bidextrous grasp at 5 months, and he started mouthing all objects by around currently. For the past 2 to 3 days, parents have noticed.
All right. Can I just suggest something, Namisha? Gross motor, when you're commenting on the prone position, it is not enough to just say looks up. It is for how long can he hold up his neck? Is he bearing his weight on the elbows or on the arms itself? right? Because looking up could be just for a momentary, right? That is there in initial 1 or 2 months also there. The child will momentarily lift up the neck. But to get a good assessment of whether the neck control is properly there in prone position, we need to comment on the duration of how much is the neck hold.
So he was able to look up prone on his elbows, but there was a wobble present. It is only present for almost 5 to 10 seconds, and then his head wobbles down.
Right, right.
And language, currently he babbles and coos. His social smile has come at 5 months, and he's recently started recognizing his mother. He can track objects all the way till 180 degrees, and he turns his head to a rattle at the level of sound.
Right. So is that normal?
By this month of age, he should be, by 5 to 6 months, we expect he should be able to look down at the sound as well.
Yeah.
Not
Right.
just at the level.
Look it directly at the level of the sound. Okay. Right. Next.
Dietary history has always been on formula feeds. He has not yet been started on complementary feeds, and based upon the amount that he was taking, his calorie intake came out to be around 1,000 kilocalories per day.
Weight gain has been appropriate. So
Yes.
you'll comment on the anthropometry later.
He's first in birth order of a non-consanguineous marriage. There is no similar history in family of any preterm delivery, dysmorphic facies, or delayed milestones. There is no history of any early sibling death in the family, and this is the 3-generation pedigree chart. He has been vaccinated till 14 weeks of age based upon the national immunization schedule. Father is a postgraduate. They live in a Pakka house, and it's an upper middle class on Kuppuswamy scale. So as to summarize, we have a case of a 6-month-old male child, corrected gestational age of 4 months, 1 week, born to a primigravida mother, non-consanguineous marriage with uneventful antenatal history, born at 33 weeks of gestation, LSCS, with weak cry at birth with respiratory distress requiring oxygen support, mechanical ventilation, surfactant, single dose, was discharged at day 14 of life with gradually increasing head size and head lap till 3 months of age postnatally.
All right. Anything about the vision in this? That you had complained that he was not responding properly?
With decreased responsiveness, decreased interaction with parents in the first 2 months of life.
All right. I don't know if it will come in the summary like that. Decreased
Because-
responsiveness, right?
Because currently, according to parents, he's able to track objects,
Okay.
colorful objects.
Hmm.
Should I start with the general examination?
Nimisha, in the history, we have to describe all the milestones in a sequential manner. You did so. Can we go back to the history? Just the development history. Yeah. So what you have discussed is that the child is doing at 5 months. So what about the sequence? How was the sequence? Is it like we in generally there is a difference between a history and examination. In examination, you will tell what is the position now, isn't it?
Yes, ma'am.
But in history, you have to give the sequence. At 2 months, child started smiling, and at the same time he was able to partially hold the head or whatever. And you have to give the sequence of all the milestones. Like in fine motor, you have still given some of them, but in motor and go to the next slide. So try to elaborate all. For example, social. You have just it's the social smile at 5 months and can recognize. उसके बाद में उसका कुछ नहीं है. There is no cooing or interaction, and
Ma'am, your mic has gone off.
sorry. He has not achieved cooing and laugh.
No, ma'am, only babbles and coos. He babble and coos at 5 months. He has not started laughing yet.
But cooing, but wait, that's what I'm saying. You have just talked about social smile. You have not discussed. Try to give all the milestones in a sequential manner. That is what is developmental history is. So developmental history should give us the idea whether it is a progressive disorder or the child is deteriorating or how is the child or it is the static, isn't it? So that should be very, very clear. And we have not discussed in the history about anything about the tone
No,
of
ma'am.
the child.
No, ma'am.
Don't you think it's important?
Hmm.
Did you ask?
Yes, ma'am. I asked if they have any difficulty in the baby wearing diaper, or or do they that the child feels a little floppy in their
Yeah.
So the
Yeah.
parent
So
should
that's
that.
very important. So your history should tell us that it is a progressive disorder. It is how is the tone, how is it's improving or deteriorating. Everything should be there. Okay, not the CT scan. We are not interested in ultrasound and CT scan. We are interested in all these things. Okay.
Okay.
Okay. Good. Carry on. Carry on.
So in general examination, the baby was sitting with support in mother's lap comfortably on room air, appeared alert with knees and elbows in flex position and back is curved. His temperature, he was afebrile. His respiratory rate was 28 cycles. Heart rate was 134 beats per minute. His capillary refill time was less than 3 seconds and the color was pink. So in anthropometry, I would like, his weight was 5.6 kilograms. His head circumference was 45 centimeter and length was 61 centimeter. So we plotted it on the charts. So as we can see, his weight for age is between 0 to -2 standard deviation. His length for age is at -2 standard deviation. And his head circumference is just at 3 standard deviation, between +2 and 3 standard deviation for age. In head-to-toe examination, the child had no pallor, icterus, or cyanosis. The cranium was normal. The anterior fontanelle was at level and was open. It measured around 1 to 1.5 millimeter. There was no overriding of sutures, no transillumination or crackpot sign. There was no facial dysmorphism, cleft lip or palate, or cleft palate. A Mongolian spot is present on the back. There were no birthmarks or macules that were present. His genitalia was normal and bilateral testes were descended.
So, Nimishan, you're getting macrocephaly, right, in this child. So, would you expect overriding of sutures or would you expect separation of sutures?
Separation of sutures.
Right. So,
The sutures were normal, ma'am. There was no separation.
Right. So, at 6 months, AF was just 1 mm. Are you sure? Do you want to correct the reading?
It was the size of my little finger. I measured it with the
Size of the little. That's it. But still, it's landing on more than 2 standard deviations. All right.
So should I move ahead with the examination, ma'am?
Yeah.
So the infant appears active, alert, playful, was dressed comfortably with spontaneous movements present. His GCS was 15 by 15. And this is I would like to start with the Hammersmith infant neurological examination. So I've started with behavior first. So before starting his entire examination. So the child was interested, was smiling and appeared friendly. So now, since we are going to be going in the order of the neurological examination, so the assessment of the posture, the head of the child in sitting position was slightly to the side and would wobble backwards during examination. His trunk, he was sitting with support but was curved, and his arms were in neutral position. They were slightly bent at rest. His hands were open, and his legs while sitting with support were slightly externally rotated. And his feet, while trying to make the child stand, were in neutral position.
Right. Can you just go back, to this page? I wanted to clarify something. So, Nimisha, when we're marking for legs, right, you see there are two headings, in sitting and in supine. Right? So you have to mark for both of them. You have to observe the legs even in the sitting position. For a child who's not able to sit, you support him with your hand. With supported sitting, you see whether the knees are bent or not while sitting, right? So when you have to mark both the
Okay.
postures in sitting and in standing, and then how, if they're two different measures, right, then you take the average of those two things and score it accordingly,
Okay.
right? But we cannot skip marking a posture.
Okay.
Similarly, in feet, right? So it is in supine and in standing. So for less than in this thing, in less than 6 months, we do not see in standing position because they hardly bear weight. They cannot bear weight of legs, right? So even in just supine position, it works.
Okay. So the movements, the movement, there was spontaneously the child was moving. There were voluntary movements that were present that were normal in quantity and they were smooth. There was no spasms or any tremors that were seen or any writhing movements. There were spontaneous voluntary movements present. Then for tone, this is for both right and left that I have marked the scarf sign. There were it was the elbow was not crossing the midline. And in passive shoulder elevation, while we stabilized the shoulder of the child and passively flexed, the body slightly lifted upwards in passive shoulder elevation. Then in pronation and while pronating and supination, there was no resistance that was felt in the baby's arm.
In forearm.
In forearm. And in hip adductors, the angle was around, the adductor angle was around 150 degrees that was present. And the popliteal angle, it was present around 120 degrees was present in both left as well as right. And in ankle dorsiflexion, the dorsiflex angle with the baby's foot was not touching the leg, the dorsal surface of the leg, and it was around 45 degrees that was present. On pull to sit, the child did have a head lag that was present and was wobbling. And in a ventral suspension, the baby was able to hold the head in the midline. But it was not stable. There was a slight wobble that was present for the baby.
Right. So, okay. So the head lag, if you see, there's so many things that are coming that are showing that there's a head lag in so many positions, in pull to sit, in prone, even in your sitting position, the head was not held in midline. So we can't say that head control is achieved as of yet, right? It is not achieved. Okay.
In reflexes and reaction, the arm protection, we pulled the infant from one arm and we noticed how the other arm responds to it, and the baby tried to move the arm towards that side. So that was
All right. It's unlikely, actually, Nimisha, unlikely that a less than 6-month-old will bear weight on arm and hand extended. Are you sure it was not slightly flexed? It could be. We have to check that again, okay? And yeah.
in vertical suspension. While I was trying, he was not kicking symmetrically in both legs. Like he was trying, but he was unable to do so. It was like a poor kick. It wasn't a proper kick as you would expect in a 6-month-old baby.
In both the legs, right? You did notice any asymmetry.
In both legs, it was poor kicking, but not scissoring. Like, and in lateral tilting, we held the infant up vertically and we tilt the sideways to see how the child's trunk and spine tries to move. So the child was trying to move his trunk with his legs, but head, he was still not able to turn so well.
But he was maintaining the head and the legs above the level of the trunk like this?
Yes, above that he was able to do.
Hmm.
And then tendon reflexes, the biceps and reflex was elicitable, the knee.
Hmm.
Then the facial appearance, the child was smiling, and he was also reacting to stimuli. So if we tried to show something like the mother's face he was seeing, or if there was a bright toy, he was responding to it. And the child also had a good sucking and swallowing. I saw the child feeding as well, and the visual movements, they were normal conjugate eye movements, and he was completely able to track the object still 180 degree. And when a rattle was held far away, he was responding to the rattle on both sides equally.
All right.
And then this is for his motor milestones. So his head control, there was wobbling that was present. In sitting, he was with support, but at his hips and his elbows, he was present with support. And at a voluntary grasp, when I gave him any objects, he was using his whole hand to grasp the object.
Mm-hmm.
And kicking in supine, he was able to kick, but it was a poor kick, and he was not able to lift his legs. And rolling to side, if we tried to support him, he could only roll slightly towards his side, but he was not able to roll from prone to supine.
No, okay.
Sorry, ma'am?
Yeah, so he was able to roll from supine to side
Supine to side, ma'am, yeah.
on his own.
No, if we gave him some, like if we showed him some colored object or a rattle, then, and if we had to support him, then he would slightly try to roll from his supine to his side position.
So I'm not sure whether it is there or not. Okay.
And crawling, only on elbows, he was just able to stably sit on his elbows. He was trying to crawl, but crawling was not present as such. And standing he was not supporting his weight. His total Heinz score was coming out to be 66. So if we take this child's corrected gestational age, it is 4 months and 1 week. So it is the first column that is present. And in this, the optimal score is considered to be 67 and the cutoff score of CT is 56. So I have marked it here. I will just zoom in and show this. So this is something, this is the Heinz scoring system for the corrected gestational age. And the child is just coming at the borderline between the optimal score and the cutoff for CT. So he will require more monitoring and stimulation, and will require more therapy. And there is no asymmetry between right and left that is present.
So what do you predict? What would be his neurodevelopmental outcome later?
So he will require more monitoring as well as stimulation, but he is at a risk that he could develop cerebral palsy, but it is there is less.
Is it just for CP? Is it just for CP? We see that any very mild risk of neuromotor dysfunction might be there. Because we're not getting any tonal abnormalities as of yet. Right?
And he's way above the cutoff score of 56. So with enough stimulation and exercise, most likely he should not have a poor neurodevelopmental outcome, which is important. But if such a child is missed early on and continues to deteriorate, then by the time, if he's currently at 66, but by the time he reaches maybe 1 year of age and it is static like this, then he is going to have a poor neurodevelopment at 2 years of age.
Right. So you keep in mind that your assessing after 2 months of intervention has already been done and there is some improvement that we've noted. So, right.
So I would like to continue with the central nervous system examination for all the elements that were not covered by Hammersmith infant neurological examination to complete our assessment. So first, the cranial nerve examination, the bilateral pupils were reactive and visual fixation was present till 180 degrees. The child turns his head to bright objects. For third, fourth, and sixth doll's eye was present and visual pursuit was also present. There was no nystagmus or gaze palsy. In fifth and seventh, there is facial symmetry. There is no drooling or ptosis and corneal reflex was present. In eighth, a startle response to sound was present and the child was able to turn just at the level of the sound. 9th and 10th, there was no pooling of secretions and I saw the child feeding. So he was feeding and gulping well and there were no tongue fasciculations observed. For motor system examination, the bulb, it was bilaterally symmetric, appeared symmetrical in upper as well as lower limbs. His mid-upper arm circumference in right and left Upper limb was 11.5 centimeters, and in the lower limb, 2 centimeters above the knee was 15.6 and 15.5 centimeter respectively. Then in tone, his posture, he was able to sit with support, and his legs as well as upper and lower limbs both were in slight flexion with a curved back. And on exam,
Nimisha, no, I don't think he'll be able to sit with support. Sitting with support is sitting with his own support. He was able to do that. His neck was wobbly, yeah, so you can't say sit with support. Sitting, giving your hand support is not sitting with support. Okay.
and his muscle appeared firm. There was no floppiness that was present, and in the tone was there was no resistance to any passive flexion that was seen, and the adductor angle and popliteal scarf, as discussed in Hine, was normal. He was spontaneously moving all limbs, and his knee reflexes were 2+, and plantar was normal. There was plantar flexion present. Gait assessment wasn't done because the child hasn't started walking, but there were no abnormal movements seen. Sensory system examination, again, because the baby is too small to do sensory examination. But yes, whenever the child was touched in any limb, the child did move away from that stimulus. And in cerebellar signs, there were no abnormal movements, tremors, or nystagmus present, and his spine was normal. For neonatal reflexes, Moro's was absent, grasp reflex was absent, asymmetrical tonic neck reflex, I was able to find. I tried it twice. Once he was able to do, and once he wasn't able to do. Sucking was present, but rooting was not there, and there was no cross extension that was seen.
But Nimisha, you said that he was able to roll from supine to side or whatever. Yeah.
Yes. Supine to side, ma'am, only with a little bit of support.
So with support, ko to we cannot count. So if asymmetric tonic neck reflex is present, what developmental milestone gets affected?
Rolling over, pivoting.
है ना, तो अगर यू हैव टू बी केयरफुल, अगर आप किसी में कह रहे हो रोल ओवर हो रहा है या साइड टर्निंग आ रही है तो अनलाइकली है कि ATNR होएगा, तो यू हैव टू बी वेरी केयरफुल whenever you are speaking. It should not be contradictory. Okay.
Yes. Then developmental examination. So in gross motor and ventral suspension, the head is held in the same plane as the body, but a slight wobble was present. In pull to sit, head lag was present. And in prone position, he was able to weight, he bears his weight on his elbows and forearms, and was able to hold his head and chest off couch, but again, his head used to wobble back down. And in sitting, he sits, as ma'am said, I had written with support, but that is only with support of a pillow or a mother's back, and his back was curved.
That's not sitting with support.
Mm-hmm.
So his developmental quotient will go down even more. It would not be 75,
Yeah.
come down to almost 65% then, because I'm 2 more months.
Because and pull to sit also with head lag, we also
Head
comment
lag.
the curvature of the back, whether it's straight, whether it's completely curved, slightly curved.
So it is very important whenever you are commenting on head control, the child should achieve head control in all the position. Especially in spastic child, you would see in one position, it looks that the child has achieved, at 2 months only the parents would come and say कि वो तो पूरा उठा लेता है, गर्दन उठा लेता है. So that's not head control, because the moment you do the pull to sit, you'll see there is a head lag. So as you have already mentioned all the 4 positions, that's very nice. But all these things should be taken care. Okay.
Fine.
Ventral suspension, pull. 4 चीजें, हाँ, 4 चीजें होती है ना. Supine.
Vertical suspension नहीं है मैम, इसमें मैंने लिखा.
हाँ.
Vertical suspension.
Ventral एक supine में लिखो position. हाँ, इसमें 4 position में होता है, sitting में. हाँ.
180 degree flip होता है ना उसमें. So supine, pull to sit, ventral, then you go in vertical suspension, then you go to ventral position and prone position. So you do it in a circle actually.
ठीक है. हाँ, तो ये सारी चीज, सारा कुछ मेंशन होना चाहिए. हाँ. So do you comment on CDC grading also? Are you aware of that? No? Okay.
ठीक है. Then fine motor, the hands were open and he was holding all objects with his full hand. He tries to get his hands in the midline and hold with both hands, but cannot transfer.
Exactly for her. Okay, cannot transfer. Okay.
Currently, his social smile is present. He watches as the mother goes around the room. And language, he's currently able to babble and coo. And
ये
in
तो 4 महीने का बताया ना तुमने,
corrected gestational age, ma'am, 4 months है.
है ना? तो
हाँ.
सोशल 100% बोल रहा, सोशल स्माइल ही बोल रहा अभी तो आप. तो और क्या होता है 4 महीने पे? लाफिंग आ जाती है ना,
Laugh out loud.
हाँ.
है ना? तो फिर हाँ, तो आपको ये देखो. हाँ,
He's not started laughing. He's only cooing as of now. He's back.
100% लिख रहा ना, देखोगे आप. हाँ, ठीक है.
Hearing, he turns his head at the level of the rattle, but not above, not below it. And a vision, he can track bright objects till 180 degrees. So his overall development will now decrease. I had written 95, but it will come down to around 85 now because.
Okay, overall development में कुछ ऐसा, there is no need to comment because we see development in different domains, right? We see there's an evident gross motor delay when compared to social and language. So rather than commenting on overall developmental quotient, you just say with gross motor delay, with predominant gross motor delay.
Then just to complete the examination, I did the rest of the systems as well, and there were no findings present in any of the other systems. His respiratory, cardiac, and abdominal system were normal. So as to
टोन और वो सब मेंशन कर दिया आपने, टोन वगैरह का बताया?
No, CNS examination.
मैं बता दिया था ना. हाँ, ठीक है. नो रेजिस्टेंस. ओके, ओके, ठीक है.
So as to summarize, we have a case of a 6-month-old male child, corrected gestational age of 4 months, 1 week, born to a primigravida mother, non-consanguineous, 33 weeks of gestation, born via C-section, weak cry at birth with respiratory distress requiring oxygen support, mechanical ventilation and surfactant single dose, discharge at day 14 of life, with gradually increasing head size and head lag till 3 months of age postnatally. On examination, having macrocephaly plus 2 plus 3, a standard deviation with mild gross motor delay.
Another thing to mention in gross motor delay is always the tone. So with normal
Tone.
and details, right? Because we need.
So the final diagnosis, a case of high-risk infant, moderate risk category with macrocephaly with isolated mild gross motor delay with normal tone and reflexes.
माइल्ड की जगह आप अभी माइल्ड और मॉडरेट तो नहीं, आई थिंक यू कैन प्रिडोमिनेंटली ग्रॉस मोटर डिले कर सकते हैं ना, मैक्रोकेफेली विद. हाँ, तो व्हाट डू यू थिंक इज योर डायग्नोसिस?
Ma'am, this is a high-risk infant with the current he requires requiring early stimulation.
नहीं, डायग्नोसिस क्या है बच्चे? डायग्नोसिस मैक्रोकेफली बता रहे हो ना आप इसको. मैक्रोकेफली क्या है ये मैक्रोकेफली? Looking at the history and examination, what do you think is the macrocephaly is due to? Etiology.
Hypoxic ischemic encephalopathy with perinatal asphyxia or intraventricular hemorrhage, which leading to macrocephaly.
Leading to hydrocephalus.
Leading to hydrocephalus.
Then macrocephaly, right? Because HI in itself would predominantly cause microcephaly.
तो जो मैक्रोकेफेली है, तो इसमें आपको क्या लग रहा है? अरेस्टेड, इट्स मोर ऑफ अरेस्टेड हाइड्रोकेफेलस.
Yes, ma'am.
Yes, because it is not only hydrocephalus. You have given the history that the child has been monitored over 2 months and there is no further increase or there is no further intervention is required, surgical intervention. So it is more like an arrested hydrocephalus, isn't it? Yeah. ठीक है, so what investigations do you do in such children? क्या investigations करें?
First, we have to do, after doing a complete neurological examination, we will have to do a neuroimaging for this child. Ideally, this child at the time of discharge should have undergone a cranial ultrasound itself, which would be a preliminary investigation. But if at that point of time cranial ultrasound hasn't been done, now we can go ahead either with a MRI scan, which will be our investigation of choice. And along with that, the child also needs to undergo hearing as well as vision assessment. All of these investigations should have happened at delivery and discharge itself, post-delivery and discharge. Right now, we will do vision assessment, hearing. Along with that, we will have to do developmental screening tests. So we should have started at 3 months of age with his developmental screening assessment, and then repeat again after stimulation exercise, or again review after 6 months if it was normal. So 3, 6, 9, and 12 months you would do
the screen. So ये जो आपको एग्जाम में ये हाइन मिलता है करने के लिए, how would you do it?
You just have to remember the points of at least the tone, posture. Even if we can't remember this, tone assessment, posture assessment, reflexes.
You have to be well versed with all these tests. What is the other test which can be done in a high-risk baby which has a better sensitivity to figure out whether the child has a tone problem?
Amy's Telson.
Emil Tyson? No.
Tone. Tone.
Not just tone. See, tone is a indicator of your neuromotor maturity in a child, right? And any dysfunction is present. Initial sign would be tone disturbance or neuromotor dysfunction in a young child. We cannot assess anything else. So any which can predict later onset of neuromotor dysfunction.
General movements, general movements.
Yeah. So that's very so that's a very important test and has a better sensitivity than especially in younger ages than the MRI to predict the development of yeah. So in fact, a lot of people are there. We are going to conduct a workshop for the PGs on 2nd of August. Okay. For this high risk high risk infant, how to assess all these full day workshop, Hein and all these journal movements, how to do, and all those things will be taught to you. So I am that will be informed to you. Dr. Ashima will inform you, Nimisha, and you can circulate with other PGs as well. That will be useful, especially for the exam going, and during exam you have to know how to do all this. So that will be a hands-on workshop that and different developmental screening tests and all those tests will be taught to you. So I request all the PGs and all those who are attending can attend that workshop. That's on 2nd of August. That's Sunday. So it will be easier for you to attend that workshop. Very, very well presented, Nimisha. Anything else? That's
a discussion to carry on with, so you can go ahead, Nimisha.
Just for completion, so that everybody knows, this case I presented to us in March 2026, and this was his initial MRI. This was the first MRI that this child underwent, which showed that there was evidence of hydrocephalus with evidence of prior germinal matrix hemorrhage present on the left side, and overall features are suggestive of past intraparenchymal and intraventricular hemorrhage. So after this, the child was advised early intervention exercises along with close monitoring. He was referred to child developmental clinic, and he has been under follow-up for 2 months. Hearing and vision testing was done. BERA was normal, but a VEP repeat evaluation has been advised to the child currently. So after those exercises and everything, this is the repeat MRI, which was done in May 2026. there has been no increase in his CSF, no increases in hydrocephalus, and there is no CSF seepage or worsening. So it is.
Can I ask a question, Michelle? Why was the VEP advised? Is it normal to advise VEP? What are the indications? What do we usually do for vision assessment otherwise?
We ideally, in our ROP screening, we do an indirect ophthalmoscopy. And
Right, so that is for just for the ROP, right? Just to see the retinal vessels. So you know the follow-up protocol for ROP at discharge?
so
And,
yeah, this child, according to less than 34 weeks of gestation, if the birth is there, or if the birth weight is less than 2000 grams, then ideally at 4 weeks of postnatal age, it has to be done. But if it is less than 28 weeks of gestation, ideally we should do it at 2 to 3 weeks of postnatal age. And then we stage it according, do our ROP staging, and based upon our staging, we will do follow-up of the.
Okay, so your ROP is done right in this child. For example, ROP was coming normal, nothing was coming. And so why was a VEP indicated in this child? We don't usually, you've seen our prescription, we don't usually send them for VEP. What are we trying to figure out?
So we're looking for if there is any CVI, cerebral visual
Impairment.
We're looking for CVI because that could also
Is
sometimes
it cerebral or is it cortical?
cortical visual.
Check. Right. So when we see the posterior visual pathway is affected or not, and in such children who are high risk, it is definitely a possibility to consider, but it is not routinely indicated to do VEP for everyone. We must have seen some clinical signs picked up on it, and that is why initially VEP was recommended. So what could be the initial signs for VEP, for CVI?
If the child was not tracking objects well, or
What would be the first thing? First, tracking doesn't come first, no? So fixating
there was no fixed visual fixation that was
fixation and following, yeah. Right, so that is not coming. All right, and then even in this we see fine motor delay also. They can't reach. Right. So only then VEP is indicated. So for vision, and otherwise a hearing screen is indicated in all. That you know, right?
So we have to do autoacoustic emissions for all children. Ideally, in high risk, we should also do an automated auditory brainstem response because sometimes OE can miss that. So all our high-risk infants, those who have stayed in NICUs for greater than 2 weeks, had preterm delivery, required mechanical ventilation, or had any antibiotics that were ototoxic, all of them should undergo an AAVR.
And we cannot just solely rely on OE at all.
And we have to do it by 1 month of age. Then ideally, we should have a diagnosis by 3 months and an intervention by 6 months for a hearing.
Why should we have an intervention by 6 months? We can wait till 6 months, child is not responding. What will happen?
The language and social cues all depend upon hearing as well. So we will never, if we do not intervene early, there will be delays that will start coming in his language and social learning as well.
Yeah, so it has been seen even if you miss even if hearing is not correct at 6 months of age, there is some sort of persistent language delay that will be there. So it has to be at the earliest picked up and corrected. Okay, right. What else? You did neuroimaging, you did OE, and
we did hearing assessment, and then we will have to do developmental screening evaluation also for the baby.
Anything else also you want to do? You want to check, which is common in children?
Nutritional assessment and adequate micronutrient supplementation needs to be done.
All right. And so we always look out for DDH. That is also very important part. So even a ultrasound hip is recommended in children, right? And especially if we are seeing increased tone early in infancy, then we should CT. We should do an ultrasound. Okay.
So an approach to a high-risk infant, these are the infants who are at risk for developmental difficulties due to exposure to known risk factors before, during, or after birth, including preterm infants, infants who have special healthcare needs or dependence on technology, infants at risk because of family issues, or infants with anticipated early death. So this is just a guideline to which infant we can call a high risk. So our infant was preterm and he also had certain dependence on healthcare needs in the initial part of his birth. So hence he became a high risk infant. So there's a risk stratification. So based upon our baby's history, we classify this baby into moderate risk stratification because the gestation for this was 33 weeks. His birth weight was mild, but he, as we'll see later on, required mechanical ventilation for 4 days, which made him moderate risk.
Right. And a lot of antenatal risk factor also adds on to the moderate risk, right? Eclampsia. He had an absent flow, right? On
He had
Doppler.
decreased fetal movements.
Decreased fetal movement.
Should I discuss them briefly, ma'am?
Right, so you can just give them a reference since we're almost reaching the end of the time that we have to stratify according to the risk on how we want to follow up the children. So it could be mild, moderate, or yellow, and as traffic light system is followed, red, green, and yellow is given. For high risk, what you want to do is now important. For this risk assessment, you can share the link. So
Okay.
there is, yeah, so the IAP gives these guidelines in which there is a quick table for risk stratification. So everyone can figure it out and, take its reference. But the thing is, once you stratify, what next is to be done? So that you can discuss.
So we have to divide if the child requires early stimulation, early intervention, or definitive therapy. So early stimulation would be required for all mild risk infants, and ideally all neonates who are admitted into the NICU undergo early protective neonatal care and early stimulation. So this is a algorithm that was given in the guidelines. So ideally on first to second day of delivery, the parents are introduced to the care of their high-risk infant. This is an early parenting program which makes the bridging for home care easier. The mother is encouraged to express breast milk and to be a part of the rounds. By day 3 to 7, infant position swaddling becomes important. It is important that parents visit the NICU and touch, speak, comfort the baby, train the parents for diaper changing, feeding. In this, it's also important that the sound, so there needs to be around 45 decibels of up to 45 decibels of sound level is allowed in NICU. The feeding of the baby is not dependent upon a schedule. It should be ideally based upon the baby's cues. There is swaddling and nesting which is done so as to give comfort to the baby. These are all strategies which have proven to improve the neurodevelopmental outcomes at a later age.
Right. So this is a part of the developmentally supportive care that you give to a child when he is admitted in the NICU itself. But on discharge, at the time of discharge, we categorize the risk of the infant. All the NICU kids who will be discharged will have some of the other risk. And at the time of discharge, they have to be stratified according to the risk, and the individualized follow-up plan has to be made. Right, keeping up all these things in mind.
So for early stimulation, ideally early stimulation is home-based practices are taught to the parents, and then we do monitoring for the kids. For early interventions, it is both hospital as well as a developmental clinic based, and both have to be combined. And when there is a high risk, so specific interventions are planned based upon the diagnosis. So these are early intervention procedures. So such as in this baby who we required to achieve head control. So the caregiver should carry the child in an upright position, slowly lift the child from lying down position, holding at the upper limb at the level of the axilla to sitting position. We slowly put the child back in the lying position. So this stimulates to lift the neck up and hold the head. And it has to be repeated at least 4 times per day for 5 minutes. So if the child is in prone position, is not able to lift up head, stroking of the back is done towards the mid-trunk. All of these are early interventions that are done. So there are certain interventions for sitting as well. where you make the child slowly come up to a sitting position and then make them lie down. So these are all specific interventions that have to
Yeah, anyone can teach them at the time of discharge, right? These small activities that can be done. But what needs to be kept in mind is that development is always in a sequential manner,
be.
right? So when you're telling them, you don't give them early intervention for standing when they're getting discharged, it doesn't make sense. You start with just with neck control, with early stimulation. And on follow-up visits, we keep on increasing the level of intervention. That has to be kept in mind. Not everything needs to be taught. At 2 months, we don't need to do intervention for sitting right now. Right?
So as to summarize, first, there are risk stratification. There are early interventions where you prioritize early stimulation, developmental screening, and interventions at institutional and state levels. Then family involvement has to be there for kangaroo mother care, bonding, as well as developmentally supportive care. Routine care has to be done, such as pain management. Feeding has to be done according to the baby's cues, and a routine care according to the behavioral cues. Nutritional supplementation, complementary feeding has to be done. Mandatory screening for growth, neurodevelopmental delays, sensory impairments, and genetic disorders also needs to be done. Follow-up programs. So these children need to be kept under continuous follow-up and need to undergo monitoring and imaging that is as needed for high-risk infants. And the interventions need to focus on all cognitive, language, motor skills. And then, if needed, then diagnostic tools such as MRI can also be used, or advanced genetic testing as well, depending upon the baby's requirements. And preventive care, obviously, we have to maintain sleep hygiene, early speech therapy, visual stimulation for preventive strategies.
Right. So very important part that you brought up here also is it's a multimodal developmental support, right? Because when we are saying it's in high risk infant, the child is not just at a high risk for motor delay or for CP. You understand that, right? It is for all developmental disorders. The child will be they can develop language disorders, they can develop learning disabilities because they were a high risk child, right? So it is not just CP that we are looking for. So that is why when we are intervening, it is a multimodal developmental support, not just motor always. All milestones have, all domains of development have to be kept in mind.
I think this was the last slide.
Yeah. Very, very well presented, Nimisha.
Thank
But as Dr. Ashima has already discussed, I would also like to highlight one or two things. These days, we focus more on the habilitation rather than the rehabilitation. That means you have to prevent the disability, especially in first 1,000 days of life, first 3 years of life. So there comes that whatever stratification you do, you have to do the interventions and stimulation as much as possible so that you can prevent disabilities. The focus should be that, and that can be done by the pediatrician, and they have a good they have a role in that habilitation program. So focus on all these early intervention, and those who wants to learn about this more can connect with us. That's not a problem. Early intervention is very, very important aspect that pediatricians and all the neonatologists should know. Okay. We do not like in exam we are just worried about कि CP का case है CP करना है. That should not be the approach. CP is one part of the examination, but there are other important things which we have to look for: global delay, speech, language, ADHD, learning disability. There are so many things which can happen. So early intervention can prevent, and a lot of studies have also shown it can improve the outcome later on in life, and quality of life can be improved. So that's very, very important. So thank you, Nimisha. It was very well presented. And thank you, Dr. Ashima. I think we have anything else?
We have most
Any
of the things
questions?
basic which I've answered in the comments already. One question that is left is which Nimisha can elaborate. Till when will the child be followed up?
So ideally, till 2 years of age, definitely the child needs to be followed up. So but these children have to be followed up ideally till 5 years of age, till school going.
Yearly till from 2 years onwards, yearly till 5 years of age has to be done.
until 2 years of age. It has to be 3 months, 6 months, 9 months, 12 months, 15, 18, and 24, which usually coincides with our immunization schedule to make it easier
Yeah.
for these children.
Right. So we can open for any more questions if it's there. So whenever we're talking about milestones in history, whenever we are mentioning, it's better to use the corrected age,
Yeah.
which give us, that was also one of the questions. Right. So I think that is it, and we're also out of time now. These were the questions, and right. So
Thank
ma'am can take over and end.
Yeah. Thank you so much, and for active participation and patient listening. Thank you. And Nimisha, you presented quite well. And if I've already talked about the workshop, so kindly attend that workshop also. That's for you people only. Thank you so much. Good night. Good night, everyone.
you, ma'am. Thank you.
Bye, bye, bye.